Hi, Jackie. How are you? So, you know, we're recording and we're on Facebook Live. For everybody on Facebook, this is AB1400 CalCare office hours, weekly 5 to 7 p.m. Sunday office hours. We'll be starting in a few minutes. Hi, Jeanna. Let's see. How are you?
Oh, I'm doing well. I was trying to be social and, you know, do this outdoor brunch thing. And I realized, I was like, oh crap, it's later than I thought. I enjoyed this more than I thought I would. Slowly, you know, reducing pandemic anxiety, even though I still have it pretty bad.
Yeah. Actually, just, you know, we're hi Jackie, we're I have Facebook Live on, and so
Conversation, pandemic anxiety.
You know, it's 5 p.m. This is for everybody out in Facebook Live land. This is CalCare AB1400 weekly office hours. We'll launch the show at 5:05, but you're in the right place. You are in the right place.
How about you guys? Anybody else have pandemic anxiety about re-socializing and integrating back into society? Or is it just me?
No, it's also me. I'm still slowly just trying to figure out who I can kind of trust almost as well, due to so much just that I've seen people post sometimes that I'm like, who is actually trustworthy? But even then, I think vaccinated, I feel a little more confident, knowing that, you know, at least I don't have to be indoors all the time, because I do have chronic conditions. So for me, it was like an issue of keeping myself safe.
Absolutely. And I think that for me, I just felt this, you know, being a nurse and being in a political spectrum, I felt an extra need to be an example. And I know some of our politicians made some slip ups during the pandemic, you know, doing things that probably would not have been recommended. But I really felt the need to really want to be an example, and show people, you know, what to do. And even now people are like, well, June 15th, we can stop wearing masks, right? And I'm like, I wouldn't personally. if you're in groups or in crowds that you are not familiar with. I'm like, if you have a backyard, get together with your family or maybe some close people that have been vaccinated, and I'm like, maybe, but if you're going out to the grocery store, to parks, theme parks, anything that, things are opening back up, baseball games, I still think that it is advisable to wear a mask, only because I'm worried, I don't want to say worried, but worried about the variants. And I still think that, what could be coming in the fall, when flu and COVID decide to meet each other. We had a very mild flu season because of all of the masking and people were isolating, and we actually were washing our hands. I think we should keep the wash your hands PSA playing on TV. Make sure you wash your hands. And so flu season was not that terrible, but we know flu season this year will come back. We're going to be social. We're having our holidays. I know everyone's going to have Christmas and, and Thanksgiving and all the holidays that come in the winter and the fall. And so, my soapbox moment for now is that I would just be very cautious, and just keep in mind that even if that person's been vaccinated earlier in the year, they're seniors, I said our vaccination, our immunity kind of declines over time. And as we get into that fall, winter part of the year, people who were vaccinated early on, not quite 1,000% sure at what level of immunity you still may have at that point in time of the year. So I just, like I said, being optimistically cautious, but knowing that we are a society that has to have rigid kind of rules. And when you say, well, if you're vaccinated, you don't have to wear a mask, but we don't have any proof on who has been vaccinated, because vaccine passports are infringement of people's rights. Obviously, that's what people are saying. How do you prove who's been vaccinated, who gets to wear a mask and who doesn't? And that's where my concern is with these guidelines. So June 15th, here in California, I know other states have long lifted their mask mandates, but I would just say be cautious. Long soapbox moment, I'm sorry.
No, I really think you make a good point. Just for the sanitation as well, I hope that businesses still keep, having the hand sanitizer and having employees, being able to take their breaks to be able to wash your hands. I think it's one of those things that I don't feel like a lot of us really took in mind as much until the pandemic. And I'm hoping that we can still support each other that way and just ensure that we all are also safe. I was really happy not having cold or flu this year. So I'm still going to be looking out for that. Those, those practices.
Well, good. Well, we just hit 5:05, and so let's go. So I want to welcome the people here on Zoom and also people who are watching us on Facebook Live to this, which is our 11th consecutive, without fail, AB1400 CalCare office hours. Office hours are a jointly sponsored venture of Healthcare for All Los Angeles and Physicians for a National Health Program Southern California. And the purpose of office hours have been to provide a forum for education and discussion on AB 1400, which is the newly or somewhat newly introduced, as in February, single payer bill for the state of California. Dr. Ron Birnbaum, physician from Los Angeles, and Jeanna Harris, a nurse here in Los Angeles, have been the regular hosts, although we've been blessed with other folks who have pitched in and special guests and some frequent flyers who are de facto hosts. And so it's a team effort. And so we'll go into the way that we always start after just generally introducing the idea, which is to hear a little bit about AB 1400. Are you good doing that today, Jeanna?
Absolutely, it's my thing. So yeah, let's talk about the 7 basic principles of CalCare, which this is, given to us by CNA. And so we want to give a shout out to the CNA and the nurses and especially for making this great one-sheeter that basically breaks down CalCare and just very 7 basic principles and steps. So the first one here is that CalCare is guaranteed health care for all, and it's a solution to our broken healthcare system. Our system is very broken, whether you've experienced it directly or not. I'm sure you've seen the GoFundMes. Actually, statistically, GoFundMe is basically now an insurer, and that is sad that people have to depend on GoFundMe to pay their medical bills more, and to the point where it can compete with an insurance company. So there, right there tells you that this is a broken healthcare system. It will guarantee everyone healthcare as a human right. We need to bring the humanity back into healthcare. And so it's going to do that by providing universal coverage. We believe that everybody in, nobody out. And that means regardless of your race, your sex, gender, your country of origin, disability status, immigration status, marital status, income, you get the care that you need regardless of your ability to pay. We're going to create a single public program, a single payer, publicly funded program through progressive taxation, which means, if you don't make as much money as Jeff Bezos, you shouldn't be taxed at the rate that Jeff Bezos makes. Oh, but you know what? Jeff Bezos didn't really pay taxes. So maybe we should all be taxed at the rate of Jeff Bezos. JK, that's another conversation. But if Jeff Bezos was taxed the way he should, he would be paying a lot higher taxes than, let's say, myself or Dr. Birnbaum. And so that's how we're going to help fund this. And then also to cover and it's going to help cover all this necessary care in California. It's going to eliminate billions in bloat and waste. The insurance companies and the healthcare system is full of unnecessary middlemen. Some are just there to look cute and say that they led to, profit and revenue generation, but really they get paid 6 figures to do nothing. So why are they there? They're taking away from valuable care that direct from physician to patient that shouldn't be there. So this is going to help eliminate that unnecessary bloat, and it's going to save thousands of dollars on healthcare costs. Fully comprehensive benefits. So what we have now, we have Medicare, we have Medi-Cal or Medicaid, but if you've noticed, or if you've been under these 2 programs, you notice there's some gaps in coverage. So this includes medical, dental, hearing, vision, mental health. That's very important. I'll continue to push that. Prescription drugs, long-term care, and more. And so long-term care, especially prescription drugs, mental health, those are all things that the current system do not provide enough support on. And usually you don't really know that until you've had to experience it. But we see it every single day with our patients, that they are struggling to keep someone that cannot maybe care for themselves anymore in a nursing facility. Sometimes people are losing their homes, losing any wealth that they have generated over their lifetime just to pay for their long-term care. Is that how we really want to treat our senior citizens at the end of their life? I don't think so. There's no dignity in that. So all decisions about care will be made between you and your doctors and nurses, not the insurance companies. This is also going to give you the freedom to choose your provider. This is important because people believe that their insurance is the reason why they get good care, when actually it's those providers. So if your doctor is under CalCare versus Anthem, does that mean that CalCare now, or it doesn't mean that CalCare is any worse than Anthem, but your provider is there and you have the freedom to choose that provider. So you don't have a really good, probably, relationship with your insurance as much as you have that good relationship with your provider. And we want to keep you seeing that provider if you like them. But if you don't like them, we don't want you to have that burden of having this awkward situation with your doctor that you don't like, and maybe that doctor doesn't like you, and you can go out and find a new doctor without having to worry about, is this a network? But the doctor I want to see is out of my network, and now I have to pay all this money. You don't have to worry about that under CalCare. You take your CalCare card to that doctor's office, and then they say, welcome, and then go have a seat. The doctor will see you in 15 minutes. Now we're going to be free at the point of service. So no more co-pays, premiums, deductibles. When you arrive at that doctor's office, let's say it's that new doctor of choice that you're excited to see, and you get to that doctor's office and you give them your CalCare card. Whereas if you gave them your Anthem card, they would say, okay, your copay is X amount of dollars, 25, 40, whatever dollars. Your CalCare card, there is no copay. So they'll be like, thank you. Now here's a new patient form, have a seat. And that's it. you get the care that you need. It is literally just that simple. Now, there is a just transition. So we're going to talk about that. Maybe that middle management person who may, be kind of taken out as we eliminate this healthcare unnecessary bloat. There is just transition. There will be funding and programs to protect and support displaced workers who are in this insurance industry. So if that person that's maybe in middle management or works for an insurance company wants to get more training to go pursue something else in the healthcare field, they can and be funded for it. Or if they want to, become integrated, maybe they want to come work for CalCare. I'm sure that will be something that they will be able to be integrated into, because it's not that the person that's bad, for working for this insurance company. They might have a skill that may be really good for CalCare. It is actually the system. So we're not going to blame an individual person who works for an insurance company if they're a bad person, unless maybe you're the CEO, then I might blame you. But a normal utilization management nurse, they want to get into CalCare. I think they will have a very big role here. And then patient care based on patient need. No more financial incentive to avoid providing necessary care. No more, well, our rates are cheaper here, so we're going to send you to this smaller hospital, or maybe this provider who might not be able to provide the same level of care that you need just because their rates are cheaper. No more of that. And that, ladies and gentlemen, in a very long-winded way, is the 7 basic principles of CalCare.
All right. No, thank you for that. And so our main thing has been to answer questions. And there is a question there's a couple questions in the chat provided by Healthcare for All Los Angeles stalwart Paul Newman, who, if I'm not mistaken, I was not here last week, but I haven't seen a week in which Paul has not participated. Is that, Paul, has it been 11 straight weeks for you too?
Actually, I missed one because I had to do some work on the website.
Got it. You were busy doing other things for Healthcare for All Los Angeles. Well, it looks like you have a couple questions in the chat. Do you want to just say them? And are they one or two? Let's see.
Well, let's see. I remember, let's see. When I attended the PDA meeting with Dr. Bill, but this came up to my mind, and that is, how far does a single payer system go with okaying claims?
So let me ask you a question or two about your question. So one part of the nature, I guess, of a single payer is to say that there's, instead of being many insurance companies, there's one insurer, and that in this case would be the public, would be a state, and then that company, if you will, would be organized under the leadership of a board, but have obviously bigger administrative functions than just a board of 9, which is what the AB1400 defines. So and then so is your question about will the state of California then be making decisions then about individual insurance claims from providers? Is that what you're?
Yeah. For instance, my brother has cancer, but I don't know what stage it is. He wouldn't tell me. However, it's bone cancer, and there's some sort of experimental thing that he has to do. And he's not sure as a claim that the insurance companies will cover it, or they may cover a portion of it, but could lead him into bankruptcy. There's those challenges. So I'm very curious. I know for one thing that doctors will probably be making the decisions versus businessmen if we have a single payer system. This I know, but there may be some radical new way of treating something where the person who has cancer may not make it through or may make it through, and it's very expensive. How is that going to be handled?
So if I could just, this is just from the bill itself in chapter 6, which is the answer that is to a lot of our questions, which is CalCare, and this is, like I said, Chapter 6 program standards. CalCare shall establish a single standard of safe, therapeutic, and effective care for all residents of the state by the following means. The board shall establish requirements and standards by regulation for CalCare and healthcare providers consistent with this title and consistent with the applicable professional practice and licensure of the healthcare providers, blah, blah, blah. Basically saying that the board is going to establish the scope, quality, and accessibility of healthcare items and services, relations between providers and members. And basically the board is going to establish the regulations. Now, if I may be speculative, so this is not in the bill, this is just Jeanna being speculative. I can say with a very strong confidence that the board will look at the current Medicare guidelines. Those are kind of like a little bit of a standard. And they will build off of that. I think that they will not just completely start from scratch. I believe that, and thank you, Dr. Bill, because we're on the same thinking. I think that what they're going to do is they're going to pull CMS guidelines, which are national, and they're going to build off of that. Now, when it comes to experimental drugs, I have to say I do know the ugly side of that, which is we have denied hospitalizations and things for patients who were on chemo, experimental drugs. Mainly because I can't even say I quite understand it. I was just told to. But it is tricky. And I do know sometimes what the oncologist can do is talk to the company doing that and get some type of assistance. Sometimes they have like extra grant money on this program that they're doing to assist with the cost. In certain instances, not 100% true. For every single one, and I really am sorry to hear about your brother with that, dealing with that situation, because very much so it is something that's very common with the experimental drugs. And you know, I mean, it really kind of depends on the insurance company right now. But with CalCare, I could see that it eliminating the bloat, like the spaghetti bowl. By eliminating that spaghetti bowl, if the oncologist wants to appeal, let's say it's not covered, you know, and he wants to appeal to the board, the process will be should be so much cleaner than what it is now, so that there's not going to be weeks of probably back and forth that's going on now with appeals. It could be a matter of hours. It could be direct to the process. Like sometimes when I do prior authorizations, I get lucky and I'll get somebody who can do it right then and there. But I'm hoping that with the board building off CMS, and hopefully the people on that board and the committee are people who know this current system enough to say the appeals process, any authorization process that may need to happen for experimental drugs needs to be clean and efficient, and not a bunch of the spaghetti that people go through right now, because it takes weeks sometimes to get that to go through.
So Paul, I also wanted to add a little bit onto that. That's because Jeanna was also referencing Chapter 6, but there's some important stuff in Chapter 5 in the bill relevant to that question. So one is that the bill envisions that there will be, that the state will establish a formulary of what are approved medications. And I think, as Jeanna said, it will be informed by kind of some sense of what is in wide use, including things that Medicare paid for, but it doesn't, or pays for, but and also it certainly, there's language in the bill that says that there's nothing that should be like less than existing provisions. Right. But then it has some, some additional specific things that I think are relevant. So one is updating the formulary frequently and allowing healthcare professionals and clinicians and members to petition the board to add new pharmaceuticals, or also to remove ineffective or dangerous things from the formulary. And then it specifically says that the stuff that's on the formulary can't have prior authorizations or step therapy protocols that limit utilization. So it's on the formulary, it's just immediately available. And then I think there's one specific line that addresses the sort of grayer situations, which is the board shall promulgate regulations regarding the use of off-formulary medications that allow for patient access. So it still says that we know that there's going to be some things that might make sense that are not on a formulary, but it also says the processes for making those available, they're not just not available, but that the board will have to define more processes for making those available. Dr. Bill looks like he has a.
Can I just chime in with a comment? Yeah. So it's important to realize that this is something we do already. That, like Jeanna says, this is something Medicare does already. This is something the VA does already. This is something that managed care organizations do already. Kaiser, you can love it, you can hate it, but they do that too in what's called a group model practice. There's also larger, like practice by committee, say in teaching facilities, where they have really large groups that decide on best practices or hopefully scientific evidence-based practices. So all of these things are done, and usually kind of the bigger the group, the more they're able to collate all of the scientific information to exclude kind of bogus practices and treatments out there that aren't really scientific based. And that's where you get into smaller practices, like say even solo practices or concierge care that can actually be quite fraudulent care. And they're actually maybe even more likely to need oversight. So say you were to pay cash and go to some provider, because I saw your other question is, can you pay cash to be treated? If you were to go to a provider who doesn't have that benefit of a larger group model or even university setting model practice, their information may be actually pretty bogus and you could get terrible care there. So despite all the extra money that you paid to see somebody like that. So I think that's a very important concern. But the bottom line is that Medicare does a pretty darn good job of that already. And that's why we picked Medicare as the standard, not Medicaid, which is lower, and not some weird, concierge, ivory tower kind of thing that nobody really knows what they're doing, but they saw it on TV or read about it somewhere kind of thing. Hopefully that makes sense.
And another piece to the issue of your question, which is, will doctors refuse CalCare and accept cash only, is that the bill defines a system in which, if we're talking about doctors as one type of provider, that they can kind of be individuals as providers and then contract with CalCare, or they can be work as part of institutions, which institutions can be providers, institutional providers that contract with CalCare. They're paid a little differently. So institutional providers are paid what are called global budgets. So like a big, just kind of budget for that, say, hospital. And then, but an individual provider, like a doctor in an office or a group of doctors in an office, would operate under a fee-for-service arrangement, kind of like traditional Medicare is right now. Now, the bill says that if a doctor has to kind of decide to participate and sign a contract. And if they decide to provide care for cash outside of the system, then they also then agree for care that would be covered under the system. Then they agree to not play within the system for 2 years. They can't sort of be in and out at the same time. So it is the case that a doctor, according to the bill, could refuse CalCare and accept cash only, but they can't and then take CalCare and see patients with CalCare. And I think the bill authors believe, and I think they're right, that will lead to very few people doing that. Maybe a few, but very few, because most people can't cut themselves off from taking care of most people.
And imagine, a doctor would not cut himself out of Medicare. This will be that. you will not see a doctor say, oh, I don't want to take Medicare patient. Now they do that with Medi-Cal. And that's the reason why public option, which Dr. Paul Song brought very home, drove that home beautifully. Medi-Cal, they do, because the reimbursement rate just isn't worth it. But with Medicare, they're not going to take that spoon out their mouth. So, and the same thing with CalCare, if we're offering about the same or similar rates of Medicare, and they're not going to take that spoon out their mouth. And so I don't think that there will be very many doctors that will, unless they just really care for an affluent area that can afford it, which even those people, the thing about the rich people is that they don't like to spend a lot of money on things that they can get for free. And so I don't imagine seeing a whole bunch of people in Beverly Hills saying, I don't want your free insurance, because they know that that's actually more money in their accounts, whether that be foreign account they pay taxes on or not. And so I think that we really we'll see some rejection. We'll see some doctors become up in arms on it. I expect to hear the medical associations of things put out their little 2 cents soon. But I do believe when it comes down to it, just like the story of Medicare, everybody will get on board.
Super. Paul, sometimes you've been our eyes on Facebook Live. Are you able to peek there?
I looked, and I'm looking now. But yeah, Paul, if you would love to be our Facebook person, I appreciate it. I don't see any new questions there.
One slight twist on what was just said. There are definitely some doctors who don't take Medicare currently, but it would be harder so CalCare would be covering way more people than Medicare currently covers, because it would cover everybody, except for a few people who are kind of like transitioning to moving into the state and that kind of thing. So that's right. A lot harder to not take.
And actually, oh, go ahead.
No, so it is the case. Like, for example, there are plenty of, like, for example, it can still be hard to find psychologists or psychiatrists who take Medicare, and some.
That's really a payment structure. Like, mental health overall is just terrible. The system's so terrible. It just breaks my heart that there are people who are seeking help with mental health. It just, I can't even, don't get me started. But I do see something from Chris Shimizu in the Facebook chat that she was just asking, without a figure like LBJ, referring back to the Medicare discussion, do we really have a chance though? LBJ really, he did some heroic things to make sure the South, and people got on board with Medicare for it to roll in 1 year. If you don't know what we're referencing, please watch Power to Heal. But that's a good question. Ron, what is your take on that?
Well, one part of my take on it is that it's a question that's about what will it take politically to put something like this in place, and will it take executive leadership? And I think it probably will. I think it probably will take the leadership of the governor. But let me put another another spin on the question, which is, if you noticed, Medicare has been around for a long time, and because it takes care of such a broad sector of our population, so seniors and certain people with certain disabilities from all walks of life, it has not needed an LBJ to keep it going. In other words, once you put everybody in and everybody cares about something like this, it has its own built-in political power behind it that keeps it strong and that keeps it well-funded and that fights back when there are efforts to cut it. So that would be, I think as people look at different types of healthcare reforms, they might raise those questions, which is, even if a reform seems like it might be a good idea, does it have built into it the political strength to withstand the pressures of time and the demands on government? I think Medicare has, and I think for that reason, it has been adopted it is our single payer for senior citizens. The sort of is that we have things like Medicare Advantage, which CalCare wouldn't. But that is still why we've looked at that as a source of inspiration.
And just to say also, to add to that, if you do look at, different documentaries, I remember I watched one about a guy who went around the world looking at the different healthcare systems and comparing it to America. And I forgot what country it was, but, one of the politicians was like, well, I don't want them coming after me for touching their healthcare. And I'm like, and that is so kind of like complete opposite of how we are here in America, where the politicians are kind of just like, nah. When we talk about healthcare, but other countries are like, they're not coming after me because I touched it, and so, oh yeah, Sick Around the World. Thank you, Dr. Bill. That's exactly which one it was. So I highly recommend that. It was in 2008. So, because they made some references to the 2008 presidential election, where that was really kind of where that conversation started hinting, even though we really didn't drive Medicare for all until, of course, Bernie came into the picture. But, I think that is really good to see how globally the difference is. Universal healthcare is not something that is foreign to us. We're not the innovators of this, okay? We are literally the antiquated Model T of healthcare when it comes right now in the world, when it comes to a healthcare system. So we're very antiquated, and it really baffles other countries' minds on why some people aren't covered. What do you mean you have to pay, or what do you mean you don't have insurance, And so when it comes to this bill, I think the key focus is that we're actually trying to bring ourselves into the 20th century. Even though it's the 21st century, we're trying to actually get our healthcare system into the 20th century. Because even after AB 1400 passes, there's still going to be work that will need to be done to really make it the innovator that it has the potential to be. Any other questions? Chris said, thank you, Ron. You gave me hope.
Good. And one thing that I think came up from your comments there, Jeanna, this is just while we wait for other questions to roll in. And so if anybody has one, put your hand up this second. But you mentioned just innovation, right? So sometimes people will look and say, I think this is a kind of a too simplistic commonplace, but they'll say, well, right now we have this system that some parts of it are run by the government, but some are run by the private sector. And isn't the private sector the source of innovation in healthcare? And isn't that and will this limit that? And so I have thoughts about that, but I put that out as a question, which is, how might something like this, would it hurt innovation? Would it help innovation? Is that question off base? What do people think?
I think that question is actually really good. I think that's one that we will face because especially when people look at the government, they think of the DMV, like we can't even get the damn DMV to work. How could we work a whole healthcare system, right? I think someone even asked that before. But when you start pulling out the tangles in the spaghetti, innovation can happen so much easier. So if it means, with the consistent review of the system that should be done, I think, every couple of years they're going to be reviewing, and with the current, if you have to appeal the board for a better innovative treatment, I think that allows, using that system will allow us to say, oh, you know what, this treatment, that appeal that happened, that created this treatment that saved X amount, thousands of dollars. It really depends on how open-minded we are. And I think that will be one thing that we will have to really encourage the people who are going to be in power here, is to keep that open mind of innovation, which seems to be a very hard thing to comprehend. But I see that James has a question I saw, and I think Jackie just dropped a question in the chat as well.
Yeah, I can't tell who was first, but I'll just say, how about we'll give it to Jackie, since Jackie was the first person.
Yeah, she was the first today. Jackie, do you want to come off mute and ask your question, or I can just ask it?
Sure, I'll ask it. So I was talking to a friend. She's going to be studying medical school, and her partner is a doctor. So they're both young and have a lot of student loans, or she's going to be having student loans. She just wanted to know, given that it would be single payer, like would that affect pay, or like would medical school also be considered as in, this whole thing, or like how would things work out for doctors who have student loans? And how would they get paid under single payer to be able to also pay off their loan? So that's the question she asked, and I want to report back.
Maybe I'll take this one on since it's kind of doctory. There's a couple things. So if it's a lot of different ways to think about this, but one thing is just like if you read the bill, it doesn't say doctors are going to be paid X or Y. It doesn't say an amount that they're going to be paid. The bill talks about the mechanisms for how doctors would be paid, and then I think we could speculate a little bit from that. But even still, I think it's not 100% clear. But let me put out some of the speculation. So you could look one way, which is if you look at other countries that have and most, or essentially all industrialized type countries have some form of universal healthcare, with this, we're the only exception to that. It is the case that in many of those places, doctors are paid or make less money than they do in the United States. But it doesn't necessarily follow that in the United States or in California, if we put a system like that into place, that doctors would be paid less. So I'll tell you a couple of reasons why that's the case. So one is that on the whole, we've been willing to spend tons and tons of money on healthcare in the United States, way more than those other countries already. We just spend it in some bad places that don't benefit people a lot. And so we just might be willing to pay our doctors more than other countries. So then if you get deeper into the nitty gritty, there's, so the bill would pays people, it said they would be paid salaries if they worked at institutions that got what are called the global budgets, or they would be paid fees for service based on if they were working out as individuals. Now, and the bill says that the beginning point for the negotiation of those fee for service rates would be something like Medicare rates. And so for some people that would represent an increase in their income, for some that would represent a decrease in their income, but also there's a whole bunch of expenses that would disappear. So for example, almost all the offices where I have worked have had to have at least as many billers, or actually generally more billers than doctors, and certainly more people working at billing than doctoring. And so that costs a bunch of money that would mostly go away, because part of why billing is so expensive is its complexity. So then the other thing that I think people at least speculate on is that within the United States, certainly specialists, for example, I'm a dermatologist, tend to make more than people who do primary care. And that's probably a little bit out of whack right now. And so some amount of the centrally directed thinking about how much physicians are paid would probably emphasize, I think, better pay for primary care, relatively speaking, than our current situation, although it's not that the bill spells that out specifically. So I know that's a long answer, but if you want to give a short answer, is I think physicians in California would continue to do fine, partly because if they do really poorly, they would, if it seemed like they were doing really poorly, they would walk, they can go to other places. So the state still has to be competitive with other states in what it pays people. And that becomes its own driver for supporting positions.
And I just wanted to add, passing this will be a precedence bill. This will create a new fault line in California with how hard this will hit if it passes. When we talk about single payer healthcare, if we get this done, that will give the activist community the energy we need to really go kick down the door. I can't even say that anymore because of the damn insurrection. It all sounds negative. I hate those people. But it will give us the energy we need to go and say, you know what, now we're demanding the end of student loan debt. Now we're demanding these things because we know that we can do it and we know that you can pass it. And so I just think that passing the bill will also have this invisible precedence that will create a whole new fault line in California because it'll just hit so hard. And that's probably why people don't want it to happen. But anyway, James, I know you've been having, James and Dr. Bill, do you want to add something directly?
Just real quick to add on. One common misconception is that the longer you stay in your medical training, the more student debt you incur. So probably most of us here know that once you get out of medical school, you're no longer incurring student debt. And so once you're an intern, that's your first year after you graduate and get your medical degree. You're actually earning an income at that point and no longer paying for your training. And so that's year one. And if say you have a 4-year program or a 5-year program and then more years of fellowship, none of that incurs more student debt. It was only the 4 years of medical school that you incurred more student debt. So the longer you stay in training to become even more of a specialist, you're not incurring more debt by doing so. You're delaying more income, that's delayed gratification, right? But you are not incurring student debt by staying in your training for more years. So just because somebody's a specialist doesn't mean that they need more money to make up for student debt. Hopefully I made that clear. Thanks.
Thank you. James?
Okay. I just want to make some comments about the DMV analogy. So I've been telling people, these rolling blackouts we've been having over summer because we're using too much electricity for our air conditioners. In the rest of the planet, that's really restricted to very poor countries, not first world countries. And the reason that's happening is because PG&E are making the conscious decision they do not want to spend money to clear shrubs and fuel around the lines. And they certainly aren't going to spend the money putting those cables underground. The oil frackers we had, another third world country, which came out of an event that came out of the movie. The really low quality internet we have that Europe will not tolerate. Also, mobile phone, cell phone service. If you're paying more than about 40, 50 bucks a month in Europe, you're being ripped off. So when people say the government can't do that, we'll say, well, the private sector's not doing it either. And that's why they're doing it, because they have dividends to dole out. And if there's no incentive for them to improve the service because there's no serious competition, they don't care as long as the money's being made. Now, with regard to innovation, especially in the medical field, that's an extremely tricky thing, because a lot of people will have you believe that some boffin sits in their lab, spends 10 years and develops a cure for cancer. And everyone in the middle in the medical profession knows that research is a global thing. If you're looking for a cure for cancer, you can bet that there are hundreds of scientists all over the planet doing their bit and testing their specific piece of the pie. And what happens is that the companies come, whenever they see something that's promising, they buy out the technology usually speculative money at mammoth costs, and they basically add their own profit margin on top of that to see what they can get away with. So that is not free market, and that is not competition, and they certainly don't do that much innovation. And they do get gobsmacked. A lot of them who just don't like government simply go back to DMV. And I said, okay, well, if they bring back all the staff that they fired for budgetary reasons, then your wait won't be that long. And I can tell you now that when you go into a private bank, there are probably going to be 2 tellers there rather than the 20 you got used to many years ago. So go out, look in the real world, and back up your statements with real life examples, and that tends to keep them quiet. I also acknowledge you need to tell them, well, government has certainly made big mistakes because they're complex problems. So you need to acknowledge that, but don't automatically assume that the private sector is efficient and cheaper, etc. That's just what you're being indoctrinated with. Thank you so much. I yield my time.
Thank you, James. And then since you had brought up innovation, I just looked at the Facebook chat and I saw one from Chris Shimizu about what motivates people to innovate. Does profit inspire it the most? And so just going off what James just said, I don't think, looking at history, our most innovative things were not done out of profit. It was done out of, really, like when it comes to especially science and medicine, it was done because people wanted to help people. You know, they wanted to make things better. And what happened is that, well, the for-profit machine kind of came into it and started, you know, putting their grubby paws on it and blocking progress. I mean, I've been doing over the summer a lot of research on psychedelic medicine because it's becoming a more political topic, and I wanted to be more understanding of it. And you know, psychedelic medicine basically was put on, Paul, shrooms, and it just passed, I think, through the Senate of California. Actually, a psychedelic bill just got through Senate, so more to come. But you know, one thing I noticed is that they knew about psychedelic medicines, the positives, the good things that could happen with treating depression and treating certain things, like in the early 50s, 60s. And then all of a sudden, the government made it a Schedule I drug, which that's a big no-no drug. Like, that's like, oh no. And why did they do that? Well, then I realized that the patents for like psilocybin had been, you know, patented so early on that it's in the public domain. So public domain equal the pharma companies couldn't put a patent on it, which means, you know, no big money there. You couldn't just grab this patent and hold it for 10 years or whatever amount of years because you were the first one to grab the patent. It's a public domain now. And I'm like, so it's, you know, when that profit starts really getting involved in those grubby companies start getting involved in people who are influenced by those grubby companies, which we're not going to name names, they start making regulations to slow down this progress. Our innovation stalls. And so go back to the, you know, that initial thing, what motivates people to innovate? I think it really is people wanting to help, wanting to make a change. Maybe it is to get that scientific acknowledgement. Maybe they do want that Nobel Prize that will come with book deals and financial incentives and blah, 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 blah. But I think the initial idea is that someone recognizes a problem, like we recognize a problem and we want to solve said problem. But now we see we have got so many barriers in our way, and that is what's stalling the innovation. And if those people would get the hell out the way, I'm pretty sure the world would be a better place. But anyway, Maureen, I see you have a question.
Well, actually, it was more of a comment on what you are saying. And that is, there is no more egregious and absurd example of what you're talking about, especially with pharmaceuticals, than what we see with the pharmaceutical industry and COVID. I mean, we had 6 individuals became billionaires due to the pharmaceutical and who are involved in the pharmaceutical industry. They became billionaires. They made a total of $19 billion, the 6 of them, in this last year. $19 billion is what it would cost to give the vaccines to the entire world, to everyone that needs it. And the fact that the that so much of the research that went into these vaccines were publicly funded, and yet there are obstructions to us actually being able to get the vaccines. There are waivers that the pharmaceutical industries are refusing to give, to allow labs all over the world to give them the recipe and let them make the vaccine so that people don't die. So this is the most egregious case of really murder by state neglect, okay, by allowing these corporations to run roughshod over the entire world in a pandemic. I mean, I can't think of anything more outrageous than that. And the fact that 6 people made the amount of money that it would take to give everyone the vaccine in the world. That's really, it's beyond belief, really.
And another thing that I'd like to mention, because I mean, Maureen was focusing there on pharma and its relationship to innovation. And I think, Jackie, you were also putting in the chat that referring to some stuff Katie Porter has shared, but that I think should be understood, which is that a lot of innovation in technology in healthcare and medicine has been funded in the public sector in the United States. So that what we have a lot of is socialization of risk and privatization of profit in the healthcare innovation sector. And then, but actually, let's think about health insurance companies right now, because that's one of the biggest things is a switch from a bunch of insurance companies that that sell insurance products, or actually that the state contracts to provide to sort of insurance for people. And I think it's right to say that if they claim that they have been innovators in some way, it's completely escaped me as to what they've created that is beneficial to the public. In other words, like, it seems like most of their innovations are aimed at their shareholders' financial well-being, but they don't, so that, for example, even if you look at Medicare, for instance, Medicare exists as what's called traditional Medicare, which is just sort of a one company that is the government paying people for providing it. But then somebody said, well, we need more innovation in Medicare. So they created what is called the Medicare Advantage plans, which involve insurance companies. And what the insurance companies were claiming to the government is, we'll provide this thing of holding down costs better than you've been able to. And that is not true. Like, that just hasn't happened. And likewise, the state of California sends almost all of its Medi-Cal dollars, not all, but all, through these insurance companies. And nowhere in the United States have insurance companies anywhere actually managed to hold down costs for the public, but they've made themselves a lot of money. So I think that sometimes when people talk about innovation, it's innovation for what? And if the innovation you're talking about is financial innovation for the benefit of a few people, then I don't think that's something that's really in the public's interest. And that may be why to make a program that circumvents that.
Can I say something about this really quick?
Yeah, go ahead, Jackie. I see you have your hand up.
Thank you. Yeah, no, this is a great point. Just because when we talk about, innovation in medicine and all of these other treatments, we have to also realize how PhD students, a lot of them are in the forefront of these innovations, and they're also getting paid crap. And we know that this is one of the issues as well of exploitation of this same system, having to look for the grants, having to do so much work to be able to get the funding that we need to get these treatments. And at the end of the day, when these treatments are created, the companies are the ones who patent it, who own it, and the PhD students and the people who were behind this innovation are merely forgotten. And it's one of those things where, you know, at the end of the day, again, this innovation was made through the curiosity and the wanting of that student, of that person, those scientists who do believe in improving our conditions. And it's just so sad the way that, you know, we do treat the people who are behind these creations and these treatments, because that also goes with the same statement of capitalism and how it is that the corporations really will benefit from the very things that are supposed to be for the public. Yeah, that's all how I wanted to say.
Thank you for that, Jackie. You're absolutely right. I mean, and that goes, but going back to the innovation, people are not motivated to go for these higher level degrees when they find out, well, you know what, I'm getting ready to go this far into debt. And that may be that one person that really is that innovator that's going to do something that changes the world, the state, anything. But one thing about this bill overall is that, like I said, passing it will set a precedence that probably has never been, it hasn't been done in many decades here in the country. And I think that that will really be the motivator to bring these topics up, you know, and to maybe even attract people to California. People are saying, well, we're leaving California because of the cost, but I think that if we really push this bill, AB 1400, it passes and it gets built out the way that it should, you know, with a good board and a committee. Granted, I know I'm giving a lot of, like, you know, hope to it, but I think it will set a precedent. It will send a big message to Washington, DC, about what we need to get done. It will let other states know that they can do it too. And so we'll see other states start applying for the waivers and trying to pass their own legislation. And that's going to apply even more pressure on Washington. And I think for the students and for, you know, all the innovators out there who are, you know, kind of feeling like we can't make change, I really think that this bill would be that. So not just providing single payer healthcare here in California, it also is the innovative bill. It is the bill of hope. It is the bill of change. I mean, it really could create a huge change narrative shift here in California in the United States.
Well, I would say it's a kind of innovation in the sense that they figured this out in, like, Canada and a whole bunch of other places decades ago. So it's sort of be like, it's more like technology, like adopting technology, right? Like we're but it's, I guess the financial innovation there is that maybe the best way to manage the risk of healthcare is with everybody. It's just
maybe with AB 1400, you know,
it doesn't work as well.
Oh, yeah. Maybe with AB 1400, maybe with us having to look at these financial systems and create one and use software, that could be an innovative thing right there. Because we all know Medicare is not using their own software. They're using, like, either insurance companies or their own, they're contracting out, right? So that's an opportunity here in the tech central of really kind of the globe, to create a software that is efficient, that is, you know, quick, that can give people that opportunity to innovate. And we might not just let Google or Apple just take it. Even, you know, I would be open to saying, you know what, who's that young and up and coming who can create something? You might find your best there. I'm just thinking, I'm kind of going down this path of innovation. Innovation is my word of the day, I guess. Dr. Bill, I see you got your hand up.
Well, I was going to just kind of chime in on innovation and even kind of add on to the discussion we were having about, like, say, group model practices, whether that's encouraged or not by single payer systems, and add into that even pharma, you know, and the concept of managing risk management of risk pool management publicly as opposed to commercial risk pool management. So so the problem that kind of around all of these things is that we realistically live in a monopoly capitalist system. We do not have a free market system. And therefore, these industries, quote unquote, take advantage of us. They set up unscrupulous you know, oftentimes, you know, kind of racketeering and, you know, just holding people hostage, where they price their product based on what it's worth to us, not what it costs them to provide the service or actually manufacture the product, right? That's the problem. Pharma, of course, doesn't cost them to that much to produce those products, but it's also true in other things, like insurance is probably one of the greatest examples, or banking. That's why there's a call now for public banking. But it could also be true with, say, the Postal Service, you know, where the U.S. Postal Service does a damn good job getting, you know, I think it's Jim Hightower who says, you know, you can get a letter from San Diego to Bangor, Maine in 3 days, you know, for you know, 55 cents, as opposed to the $5 or $10 that you would spend, you know, to do that with a commercial carrier. And you know, so why do we tolerate that? And why don't we? This came up in the PA call today. Why don't we have a public pharmaceutical company, you know, or outlet like Elizabeth Warren has proposed? You know, there ought to be, I think, there ought to be public entities that run these things that have been taken over by the most unscrupulous and the most murderous of industries in our monopoly capitalist system. And right now, it's big pharma and big insurance, because they are practicing that kind of mafia, you know, hey, that's a nice kid you got there, be ashamed if you didn't buy our overpriced product and something bad happened to them, you know, kind of business model. So, and people are dying as a result, or going bankrupt. And that's what we can't put up with anymore. So, so I think that's a way to innovate publicly. It takes it out of the hands of those kind of murderous and unscrupulous commercial entities, and, you know, makes it honest, straightforward, and transparent. Is what we're trying to do, both with insurance as well as with pharma. Thanks. Just my 2 cents.
On the pharma side, I'll mention too that when you look at things that cost way too much, I think we know that medications cost way too much in the United States. And so first of all, that is an evidence that at least markets as advertised are supposed to bring prices down and not up, but that's not what happens. I think it's right that they're not that free, those markets, but that approach hadn't worked to bring those costs down. And so one thing that the bill does that in fact would make it stronger than Medicare is it makes it clear that the single purchaser of medications, in which would be the state of California, or the system, would negotiate on those prices with the pharmaceutical companies. And that in itself is a huge source of system savings. And to the extent that we have sort of identified in our conversation that a lot of profits in the pharmaceutical industry don't really come from their innovation. It comes more from having like kind of IP protections on things and that are not always developed within their walls, that kind of thing, that we can, I guess you'd say, claw back some of that money. And in an ongoing way, that's a way that we can make the whole system more affordable. And when we make the whole system more affordable, that's how we're actually able to cover everybody without just spending more and more and more, right? So one of the ideas of a single payer system, it's not just universalizing coverage, healthcare coverage. It's universalizing, it's guaranteeing healthcare and eliminating the mechanisms that extract money out of the system that would be better put to a healthcare. I see Maureen has her hand up.
You can count on me for adding the most outrageous examples. See what keeps me up at night. In talking about this, to me, one of the most recent, most egregious examples was Solvati, right? It was a drug developed for hepatitis C, which eventually kills people. Hep C primarily affects a lot of former veterans from the Vietnam War. It was developed, Solvati was developed 100% by the VA and one of the public medical schools. I don't remember which one, Johns Hopkins or one of them. No, University of Maryland, I think. But anyway, it was developed 100% on the public dime. It was developed for the problem that the VA was dealing with. When it was approved, the FDA then sold it to Gilead. And Gilead Pharmaceuticals had the right to manufacture it and charge whatever price they wanted. Well, Gilead charged $1,000 a capsule. So it was $100,000 for a drug that would save lives. It was a cure, not a treatment, a cure for hepatitis C. The actual cost to Gilead Pharmaceuticals was $1 per pill, and they charge $1,000 per pill. The VA could not afford to buy the drug back for the veterans for whom it was developed on the public dollar. Now, on the heels of this, we had a proposition, and I'm forgetting the number. I know Dr. Bill or maybe Ron will know what it is, maybe Jeanna.
Prop 61.
It's the proposition that, that had
the
the pharmaceuticals that Medi-Cal would could only be charged what the VA was charged for medicines, for generic medicines, and that went down in flames. But you look at who opposed it. You had Kaiser oppose it. You had actually Covered California. Peter V. Lee opposed it. So it's really shocking to see who jumps in, who's supposed to be taking care of patients and caring about patients. And it's always it seems to be the insurance end. Well, not always, because we also have the California Hospital Association. But here we have these drugs, that we are developing, we are paying for them, and then they're priced outrageous amounts that nobody can afford to use. And for Solvati, that's a cure. It's a cure. That should be available to everyone at $1 a capsule. They charged $1,000 per capsule. Unbelievable. Once again, unbelievable. Why we need AB1400 and a whole new system.
And one thing too is the biggest state, we have a lot of power, and we give up on it all the time. But we've seen over the course of history that, so for example, when California says, well, we want these cars to have these emission standards, well, that market it can't really be ignored because it's too big. And so we're able to do things, I think, in California. I think California is a great state to be the first single payer state. I think that there are people out there who may argue, oh, maybe it'd be better if some little place did it, but I actually think it's better if a big place did it, because that will show certain things and we're much harder to brush aside in negotiations and that kind of thing. So we shouldn't leave that power of our bigness on the table. Let's see. Anything coming from Facebook right now, question-wise?
Oh, Ron, I just wanted to say one other thing. You're right about the bigness, but Elizabeth Warren made a wonderful comment, and she said, if you feel you have no power, go public, go big public. So it's numbers, but it's also going public.
I do have a question, if that's okay.
Yeah, ask your question.
So I had seen a post, and I'm not really 100% familiar, which is the reason why I'm asking here, that they were going to expand Medi-Cal for, I believe it was for undocumented, or it didn't matter the immigration status. I remember Dr. Song talking about that, you know, being like, saying that, you know, adding more people into the Medi-Cal system could pose a bigger issue on the services. So, you know, what is it that you could say to folks, you know, who are listening in and kind of giving a refresher on why, you know, Medicare for all, well, sorry, CalCare would be a better solution than just expanding age groups or like adding, you know, more folks onto Medi-Cal instead of having a single payer?
I would say, I really want to answer this question because it's so close to my heart and my work. And so, because I take care of, in some places where I work, a lot of folks here in Los Angeles County who are undocumented, who get care provided to them through a county program called My Health LA, which is very limited. And then I also take care of a lot of people on Medi-Cal, and I see some of their some of the things that they're up against. And yes, Dr. Song was also mentioning that. So let me share a story from this, it was about a week ago. So there was a child who I was taking care of who is actually was an immigrant, but a documented one. And so I was seeing her through a Medi-Cal program. And I noticed that, like, at this particular visit where I saw her, not to toot my own horn, but I figured out she had something that was kind of hard to figure out she had going on called congenital adrenal hyperplasia. And that took a bunch of thinking, and there was some tests I had to interpret. And then I had to, you know, I spent some time talking to her and to her family. And then I did the little bill for Medi-Cal. And I think I probably spent, if you'd go much deeper into how much time I spent on that, it was well over an hour. But so I'll end up being paid $18 for that thing. And that's actually not a lot of money for what I did. And for the effort that took. And this is not about me trying to but because it doesn't pay well, there's not very many people willing to do that. And because of that, the patients who have Medi-Cal have to wait months and months to get seen, or in many cases, and now I keep seeing this, simply get told that some specialists just aren't available to them. That's wrong, like that should be incorrect, but that's what they're told. So Jackie, you're bringing up something really important, which is that we have, if you look at the uninsured in California, a big chunk, maybe 50% of the uninsured are uninsured because they're undocumented. And the current programs, with certain exceptions, so children are now, undocumented children can be covered by Medi-Cal, but other than that, they can't be. But there's proposals to cover a bunch of folks who are undocumented and uninsured by making them eligible for Medi-Cal. Now, that will take some more money that will have to come from somewhere. But what, to me, that really does is put more people into a failed system that's a part of a two-tiered inferior system and divides the crumbs in that system among more people. Now, might the people, and in some cases, those crumbs may not end up being that different from what in Los Angeles County they have between the combination of the My Health LA program and the ability to get care through that program at the county hospitals. So for me, it's sort of doubling down on apartheid in healthcare in California. And so I think AB 1400 is the answer. It's a much better approach to the needs of the undocumented. And what tears my heart a little bit is I do think some of the people are well-intended who want to make that change, But I think I've hit a point where I can no longer sort of say, I think that that's an improvement or a benefit really to people. So
And I just want to,
sorry, that was a long answer. But
I just wanted to add to that. I mean, I 100% agree with everything, you just said, Ron. But I will also say, working on the side that I'm working on now is that, I will never, if people don't have it and they have an opportunity to get something, I will never say no. But what this is like the system's already clogged, right? And it's like when you're trying to, and I'm using this as an example because I just had to like declog my sink. And it was a very funny story that we'll talk about another time. But to declog a clog, do you put more, dirt and stuff into that drain to clog it up? So if this healthcare system is clogged with people who really need care, and Medi-Cal patients are, typically they're, low income workers or, disabled, they come low health hit literacy. So they have a lot of complex chronic conditions. And that requires a lot of complex care that takes time that they're not getting because their payment reimbursement rates on Medi-Cal are so damn low that the people seeing them, they're seeing a bunch of them to make up for the income loss that they're getting. So they're seeing tons of more patients on tons of more. I mean, I know doctors who hop from like 3 different hospitals in one day, seeing anywhere from 40 to 50 patients. How can you provide good care doing that? I know doctors who are seeing patients in clinic, then they turn around, see patients in the hospital, then they turn around and go back to the clinic. And it's like, how do you see patient? How can you provide that patient that good education, that good conversation about your condition? You can't. So if you just continue to dump patients into this clog system, you are not easing the clog at all. You're just further backing that clog up and letting it fester and get sicker and sicker. And now I smell it from here to Timbuktu. And so I just wanted to say, while, like I said, I want to get care for everybody. I do not think anybody, documented, undocumented, are farm workers who are literally picking vegetables, getting cuts and bruises and, blisters on their feet that cannot get them taken care of until they're almost having to lose a limb. That is not justice. That is not fair. If you like to eat a damn avocado, you better care about that person picking the fucking avocado. Excuse my language. But I'm just saying, but if we just dump them into the system, I think that they still may not be able to get the care that they need until we unclog it, and we unclog it with AB1400. But I do think that, like I said, what the people are going to see is that, healthcare, they just want healthcare at the end of the day. And I'm not going to, continue to clog up the time. So Maureen, you had your hand up.
Yeah, I just wanted to throw my 2 cents in about it. Great examples, Ron and Jeanna, absolutely priceless. I'm going to steal them, but credit you, of course, especially with the clogging.
My sink was clogged for a while, but it's okay.
Separate is never equal. And I think we have to emblazon that into our brains. When we treat some lives as worth more than others, we are never going to get rid of a racist system, a bigoted system. We're never going to get rid of it. And one of the protections of everybody being in the same system, no more tiers, is that the quality will be good. When the governor and the janitor and you and I and my state senator all get the same exact care, and that's what we have to make sure happens. Everybody in, nobody out, equal care. There will be everything we need will be there. It will be good quality and it will be funded. The horrible thing about the tiered care is that it is not equal care. It is not equal quality care. And they don't have everything they need. People don't get everything they need. We see with LA recently, LA County, there was, a wonderful expose in the LA Times about wait times, people dying, waiting for care, and they had insurance. They had the MyCare LA and whatever other insurance the county uses. But the budget, tiered care allows chopping the budget. We look everywhere, whether it's in the federal or the state, they're always looking for where can they cut the funding. If we are all in the same system as you started out saying a while ago, Jeanna, is nobody will want that system touched. They'll want that system kept healthy, good, well-funded, quality. But as soon as we have tiered care, some people are going to work to get more and cut other people out of getting what they deserve in order to shift the funding in one direction or another. So we need a trust fund that cannot be touched for anything other than our healthcare, and we need everyone in so that it is never on the chopping block, the budget chopping block.
And hopefully that's what the CalCare Trust will be.
And if you think back to the question or sort of the discussion that was touched off by Christian Musu who's on Facebook, I don't know if she still is, but her question about, the governor or the leadership and the discussion that followed that's sort of about the political strength of everybody in, then you start to see certain things in a different light when you continue to bring, when you bring folks who are undocumented into a system that already has been sued for. So Medi-Cal in California has been sued in federal court, essentially for being racist, to simplify a lawsuit, by a group called the Mexican American Legal Defense and Education Fund, MALDEF, because specifically it has failed to do what it says it's supposed to do, and it's continued to fail more as it has become a browner program. And if you say now, okay, well, let's add in some millions of people who actually by law can't vote into that system, I think you see the logic working in the other direction, where you continue to turn that into the system for the disempowered and the system for them, where them is the people who don't have voice in Sacramento. That's why it may seem like a good idea. It may seem like it's coming from people's hearts in a meaningful way, but it's not good policy, because it doesn't have built into it its own sort of staying power and resilience, the way that Maureen was describing it. So Erica, I think you have a question.
Sorry. Just trying to unmute. Wow, this is such a great discussion. So much. Frustrated that, I don't know, the governor and all of our members of the legislature aren't on this call, because it seems like if you truly understood CalCare, how could you stand in the way? I mean, even for the governor, my God, you want to be president of the United States? I mean, we know this is your ambition. Lead with CalCare. Give Californians single payer, and you'll be a legend forever. So I'm frustrated and don't get it. But, just talking about the tiered care. So it's my understanding that that's another reason why AB 1400 is such a fantastic bill, because it doesn't have the HMO, ACO kind of, I don't know what you would call it, loophole in it, which would be a type of tiered care. And so this really, this bill avoids that. Can you talk a little bit more about that?
Well, I could say a couple of things about that. I mean, in 2017, the legislature introduced a bill called SB 562 that would have done a single payer program in California, and that bill would have allowed for the continued presence of, or the state could contract with organizations like Kaiser that do capitation. So if you want to know my honest opinion about that, if we had passed SB 562 in 2017, that we would be in a much better place right now, and that this state would have been much better off, and that wasn't sort of some kind of poison pill. So I sort of disagree. This is personal, but I do want to talk about what's in the current bill, which essentially does end capitation, which is organizations accepting money, a certain amount of money per human head, and then that organization now takes on the risk for taking care of them, the financial risk, which gives them the incentive to provide less care. I do think this is better policy. I do think this is an improvement than when compared with that bill. But I do also believe that this issue has become a mistaken one that has caused unnecessary divisions within the movement to do single payer in California. So I agree with the policy, and I always want to focus on what's in AB 1400. This bill ends capitation. Now, I guess if you're like saying, well, would a bill like SB 562 have created a two-tier system? Well, the answer is, if you don't like Kaiser, you don't go there, right? So that's different than the folks who are in Medi-Cal. They don't have a choice because they can't afford some other health insurance by definition. That's why they're in Medi-Cal. So I don't actually think that I don't think two-tieredness is the right word to describe those differences. And I do think AB 1400 gets this right on the policy side. And in that sense represents an improvement from SB 562. I'm not arguing for going back to SB 562. I just think we would be in a better place if we passed SB 562 in 2017 than we would be right now. And probably we would have saved a lot of lives in the pandemic if we passed SB 562. And so I will never apologize for my support for SB 562. Never. I mean, and you know that, and like I said, that doesn't mean that there can't be better ways to do things. There's better ways to do some things that are in AB 1400. I think a lot of people agree with that, but it represents a certain kind of core of the effort to do single payer that I think is good contemporary thinking on the topic.
Exactly. I think that, you know, trying to untangle the spaghetti is going to be hard. HMOs, ACOs, PPOs, you know, like all of this, it's really convoluted because we let it run amok for too long. Unfortunately, I mean, we're paying the consequences of the bad decisions of our predecessors and their predecessors. And we have to, at some point, create the final stand here before somebody else years from now will be saying the same thing, that they're paying for the consequences of me, you know, basically being their predecessor. So I think that, you know, there's not going to be an easy answer that's going to appease people who might work for HMOs or ACO organizations or people like me. But, you know, at the end of the day, it's that, you know, I'm sorry that some people may feel some kind of way, but we are paying the consequences of people who may not even be living right now. You know, and it is up to our current politicians to have to take the stand to unwind that instead of kicking the can to the next generation. Maureen.
Yeah, I just wanted to say, I think everybody on this call, with the exception maybe of Jackie, because she was young then, I don't know, maybe you did, Jackie, we all worked for SB 562. And some of us worked for the Kuehl bill and some of us worked for the Leno bill as well. And I know someone there, other way, there, who's been around for all of that. And anyway, so none of us are apologizing for that. That was the best thing out there at the time. But I think Kip Sullivan brought up, and I think it's worth thinking about. He said that, you know, that what he calls the loophole. It would not just apply to Kaiser. Any insurance company could form its own ACO and actually would really destroy the whole system, because you could have Anthem and Blue Cross and United and, you know, all of them forming their own COs, all become Kaisers and all claim the capitation, right? So we really wouldn't have a lot of choices if that happens. It just, why, you know, I guess the beautiful thing about AB 1400 is it answers a question like, why leave space for that to happen? It doesn't. And that's the most wonderful thing about it. But none of us are apologizing for working for SB 562. I'm not, but I do see that this is better. And once we see that something is better and we see the reasons that it's better, we must embrace it. And for these nonprofits and these foundations and NGOs that are saying, you know, the incremental piecemeal, this little group, that group, the other group, this little bit, that little bit, I would have more confidence in their goodwill if I saw them also pressing for single payer, SB 1400. But when I don't see that, and I see only the incremental Band-Aid approach, and then I see where their funding comes from, then I don't necessarily, I think that these things are diversions. And they are, yes, we can do some incremental things that will help other people, but let's keep our eye on the prize as well. So I have much more confidence in organizations and groups that push for AB 1400 and are willing to take some piecemeal steps to help people as well. But when they're not supporting the single payer solution, then I don't have a lot of confidence in motivations.
Thank you, Maureen. Oh, Dr. Bill, I saw you had a question. I think then I saw Paul put one in the chat. Go ahead, Dr. Bill.
Oh, I was just going to say, I put in the chat a couple of tools that are useful. I don't know if we can somehow get that to the Facebook Live folks, but there's a Harvard University daily metrics on COVID-19 that you can sort case counts and death counts by state, county, and congressional district, and which is very elucidating. You know, of course, you can present that to your member of Congress, their staff, you know, and then if you combine that with the Lancet Commission study that was published in February that said, you know, a single payer system nationwide would have prevented 40% of all COVID-19 deaths in America, which is ongoing. I mean, we still don't have one, obviously, a single payer system or Medicare for all. So we are still incurring those deaths now. If you think of all the people with those high-risk conditions, you know, a lot of them are still dying because they get inadequate care for those high-risk conditions and complicate, you know, and then they're exposed to COVID. So, so that's, you know, 40% of those numbers. As you can see, I threw in the chat for the US total, and then for California, you know, we've had 63,394 COVID deaths so far in California. 25,357 of those people would be alive today if we had passed and put into place SB 562. So, so I think everybody here who worked on that, you know, trying to get that passed, you can feel good that you were on the right side, you know, or the side of righteousness, even though sadly, you know, we couldn't make it happen. And that just means we need to double down on our efforts this time.
Yeah. Actually, I think Jackie has, no, thank you for that. Jackie, I think, brought us another interesting sort of angle on this in her, and Jackie, thank you for driving the discussion with just really great questions. And today, really value your participation here. But she had said that she was familiar with some reach out to immigrant groups who celebrate the extension of Medi-Cal, but didn't respond to AB 1400. So I think there's, I'll say two pieces of that. So one might be like, I do believe AB 1400 is better for documented and poor documented and undocumented immigrants than Medi-Cal and an expansion of Medi-Cal would be. I really think AB 1400 is better. So to the extent that what you're encountering is true, that represents a failure of the effort to communicate the benefits in those communities. And that says we've got work to do. And you know, and it's maybe it could be argued we should consider doing some office hours in some other languages. That would be a cool move. And try to and invite participation in other languages. But also, I think that I want to give a little nuance to that answer, just in the sense that if you look, so Medi-Cal is the devil they know, and sometimes they also don't know all of its devilishness, right? Because that's part of the nature of health insurance. A lot of people think what they have is better than what it is until they see what it's like when they need it. That's a problem in some privates, certainly a lot of private sector insurance, and some of the issues with Medi-Cal. But the other thing too is that people can rightly point to states that have expanded Medi-Cal, because that was one of the things or Medicaid, that's one of the things that was achieved under the Affordable Care Act, was making Medicaid more widely available, but it required individual states to take actions. And the individual states that expanded Medicaid generally have seen some benefits from doing that. But it doesn't necessarily follow from that just because California continues to do that it will continue to see additional benefits from that. And it may ignore some problems that were introduced into the places that did that too. So,
and just to add, oh, go ahead.
No, in other words, there is a simple fact, which is that having health insurance of some kind is associated in the broadest, most broadly speaking way with reduced death. There is a benefit to health insurance coverage that's independent of other factors. So I'll just say that.
And just, you know, Jackie, with what you're saying about why, you know, the immigrants' right groups may be celebrating Medi-Cal expansion and not saying anything about AB 1400, mainly I think it's because they may not know about it too heavily. Unfortunately, breaking the echo chamber of single payer activism and with this bill getting out of it, it's actually kind of hard. Because, you know, we might not have some of the loudest voices with the biggest platforms that, you know, are able to help us break that chain, you know, break that out that right now. And that could change over the summer, you know, and as things start really getting heated up. But the other thing is that where I really want to focus, and I feel like it's a disservice a little bit, is that, you know, trying to get into these community organizations to have this conversation, basically to take office hours to them. You know, so if you know an immigrants organization and that, you know, that you would want to do some education with, I don't mind offering my time. Hablo un poquito español though. But, you know, but I can definitely give talking points and everything, because I want to get that information into our undocumented community, our Black, Brown, you know, all the different, you know, communities, because I feel like we're not reaching them as much as I want to. And so I think that could be a lot of the reason why you might not hear it as often, is because they don't know, and they might not know it's included. I know but Baba Akili has always said, you know, when we say healthcare for all, sometimes all does not mean all. and all still excludes people of color. And so that also could be something that is being felt too, is that when we say, you know, Medicare for all, well, maybe they feel that maybe we mean all Americans, all, you know, people, documented people and not undocumented. And I think it's important to really drive that home, is that, no, we're including you too. You are included. You are my family. You are going to be covered. And I think that's one thing that I think that needs to be punched out there into those organizations. And I think we should be really trying to help, you know, outreach there too. So like I said, if you know one that wants to have that conversation, I think, you know, Ron, myself, anybody honestly that's in this Zoom room right now is probably well versed to talk about it. But I know getting definitely into the community is something we've got to do.
I think I'd actually add one other thing too, which is that it's a good idea to look at the financing of the political campaigns of some of the politicians in the legislature who advocate for that avenue of reform, because I think that people would also find a follow the money trail there that includes people who take money from Medi-Cal. Very little of Medi-Cal is just public money going to providers. It almost all in California gets filtered through more than one type of kind of insurance company and related structures. So on the way to me getting paid that $18, there were actually these other people who got paid other money. That reduced that to $18. Still wasn't much there probably to begin with, but there's other people who skimmed off some of that. So, and those people give money to politicians too. So I'll just add that.
Awesome. And I saw Erica, did you have your hand up? Did I see Erica with a hand up?
I had it up, but I think Maureen said it in chat and Ron just said it. I mean, in a sense, you know, these people are being used to make profit for the profitable. I mean, for the rich, because as Ron just explained, you know, getting signed up for these programs, yes, it does aid some, but it creates profit big time for these insurance entities, and then they're still stuck with co-pays and things that, you know, $10 or $20 to one person may not be a lot, but to somebody else could mean the difference in getting care or not getting care. So also I think that maybe in how they're, and Maureen really said it, I'm just going to voice it out loud. You know, we don't have the millions of dollars that these other organizations do to do this kind of outreach to groups. And so, you know, it's tough. We're doing the best that we can, but I love the idea of CalCare office hours in different languages. Could do 1 hour in English, 1 hour in another language, dedicate sessions to it. So I think that's wonderful. So I guess we'll just keep on working it.
And take the show on the road. Well, kind of. We're already on the virtual road. But yeah, Jackie, I think helping with the Spanish part will be just huge. Like I said, my Spanish is broken, and I think this is a good conversation. And I think definitely people will be more engaged if it's in their language, you know, their language that they can feel free to communicate in comfortably. But if it's like the heads of, you know, organizations or things like that, like I said, if you reach out and you know need talking points or anything, please reach out to us and we'll be definitely there to support you. And Maureen, I saw you got your hand up.
Yeah, that's a great idea about the different languages. And, you know, we have partners like PANA, and we can find people through that speak Korean, Tagalog, you know, different kinds of Chinese, Thai. We have people that who are with us already that that could do that. I just wanted to give a shout out to Ash Kalra, because Ron, you brought up the money issue, like follow the money, especially the political money. And I know Dr. Bill follows this all the time, and most of us try. Ash Kalra doesn't take corporate funding. I think there's one other person, and I'm ashamed I don't remember who it is, but you know, he doesn't take that corporate funding. We have Healthcare for All Los Angeles in giving our endorsement to candidates. We are only giving it to one so far, because our requirements are two things. They must have AB 1400 on their webpage, their website. They must publicly advocate for AB 1400, not, you know, single payer, not guaranteed care. No, AB 1400, we have a bill, it's live. That's what we want to see for this election cycle. But the second thing is the Patients Over Profit pledge that CNA has. And so those are our two requirements. That pledge says that the candidate will not take funding for their campaign from, you know, basically our opposition, bad actor corporate entities. So shout out to Ash Kalra, principal author of AB 1400, because he didn't just now stop taking the money. He hasn't been taking it for a long time. And I really, that takes a lot of courage, takes a tremendous amount of courage. And he also takes a lot of courage to go up against Anthony Rendon, who controls the assembly like a herd of sheep. Okay. So Ash and the few others that are really going to bat for AB 1400, you know, hats off to them. They are really the cream of the crop and deserve our respect and our support.
Thank you, Maureen. Yeah, just a big shout out to the author, principal author, Ash Kalra, and, you know, and all the co-authors and, you know, sponsors of this bill. I hope that you maintain your sponsorship and your, you know, and maintain the fight for this bill as much as we are fighting for it. And of course, we will support you in that fight and have your back. So please know that you are not alone in that assembly. And I want to give a thank you to my Senator, Sydney Kamlager, for including me in her discussions and on her committee to discuss this. And so I look forward to this summer. I know I can't wait until July 24th. We're going to have an in-person rally for Medicare for All / we're going to hijack it and make it for AB 1400. They just don't know that yet. And so I'm very looking forward to that too. And we'll probably drop more information about that as the event gets closer. So don't, you know, but I think there is a Facebook page. We may try to find a link and drop that in the chat. Any questions? Anything? Do you see anything?
I just want to say about that rally, we now have 70 Healthcare for All single payer t-shirts. So anybody that's going to participate with us, you get a nice t-shirt, okay, for free.
Fantastic. Do you see anything in the chat, Paul? I was keeping up with it and then I got distracted. Short attention span over here.
I looked and I didn't see anything. I posted
Awesome.
Dr. Bill's Harvard and the thing about COVID and all the statistics and everything. So we got that.
Thank you.
You know, maybe we should also mention, because I know that people on Facebook can't see the chat, that Alex Lee is the other, according to, I think it was Dr. Bill or Dr. Ron, that Alex Lee is the other corporate free candidate. And we have to really appreciate these people.
Yes, thank you.
Alex Lee is also up in San Jose area, as is Ash Kalra. They're both up there.
And yeah, thanks. Shout out to Alex Lee, very young and up and coming assembly member, a lot of promise. He's going to go very far as a progressive leader. So, I mean, we're in the last 10 minutes of office hours. And one thing I haven't brought up this time is what I know CalCare is. And we'll keep bringing it and driving this home until the cows come home. And cows don't come home to the inner city Los Angeles. So I'm just going to keep driving it home. CalCare is at best an exploration, okay? So for those people who are on the fence about this, those politicians, just know that AB 1400, when you pass this bill, or what you're voting yes on, you're voting yes to help us explore that, to see if we can build this system. But that doesn't guarantee that we 100% will. be able to implement it, because there's a lot that has to be built out. So upon passing AB 1400, what this allows us to do is to build that board, which, I mean, in my perfect world, I would grow that number from 9 board members to probably like 25. But that's just because I like shared governance. I'm a nurse. That's part of the nursing model, shared governance. But, you know, the 9-member board will allow to be formed, which is 5 members appointed by Governor Newsom, and then like 2 members from the Speaker of the Assembly, 2 members from the Senate pro tem. So, you know, that allows that to happen. That allows the board to convene the 11-member advisory committee. And then they get to work, and they get to work with building this bill out the way that it is stated in AB 1400. So by passing AB 1400, by voting yes on AB 1400 in January 2022, that's what you're starting. But we cannot say we have single payer until all the things that are outlined in AB 1400 have been achieved. And that goes back to the board saying, we've achieved this, we've cleared it with the treasurer, we've cleared it with the Department of Health Services, everything's been cleared. Our long checklist has been checked. And we've got funding to not only implement, but to sustain. And so I just want to drive that in there, because there's a lot of people who are asking a lot of nuanced questions that it does say in the bill, the board to decide, board to decide, board to decide. And I know that means that it doesn't give you an answer, and that may make you feel uncertain. That may make you seem like we don't have it together. And in a sense, the board will have to decide that, because this is the first time this is really happening. If we get this passed, we're going to really be venturing into the great beyond, because we haven't been able to do something like this yet, because nobody will ever let us build it out. So I'm asking you to assist me by telling your politicians to help us by voting yes in January on this bill, so that we can explore to build this out. It's actually really safe for them to do this, because they can't be blamed, because the thing can't be implemented unless we know it can work. If it can't work, if we hit some, you know, things that have to go to the ballot, like the GAN limit or whatever, you know, Prop 4, if that actually has to happen, then guess what? We can't implement it until we fix that. So we'll just be continuously building this and working on it. So that's what I just want to drive that home, because it really, I think, is something that's missed. I think that people think that AB 1400 is passed in January of 2022, and all of a sudden February 1st, this bill gets put in and everyone gets single payer. And I'm like, as much as I wish we were that efficient of a system, you know, we're not. So I just want to drive that home. And I want to tell, you know, and I want people to drive that message, so that their politicians who are, for whatever reason, shaking in their boots about this, for whatever reason, I don't know why. Jim Wood, who's the chair of the health committee up there in District 2, way up at the tippy top of Northern California, you know, if you're shaking in your boots because you feel like you might piss off some donor about this, just know that you're safe, because guess what? Your homeboy Gavin gets to appoint the board. So, you know, make sense of it. But I said, but you will appease somebody like me, who's, as the great Nina Turner says, has her hair on fire about this bill. So I just will end with that. But I didn't get to drive that home this session yet, so now I did.
So we have, let's see, thank you. We have about 6 minutes left, and maybe I'll mention one thing that, because Jeanna was just talking about some of the governance stuff, right? So the bill describes the governance of the system and she mentioned it has a 9-member board and defines who gets to appoint people on the board and how that board oversees the thing, and then also identifies 2 other bodies that are important. So one is the advisory committee. So it has a bigger group of people currently appointed by the board, who would provide sort of technical and policy advice to the board. And then it also creates another body that's the commission, the advisory commission on long-term services and supports. And so one thing that it is worth mentioning, because we haven't today, although we've talked about it on some other office hours, is that that CalCare would create a universal long-term care benefit, which is a big problem in California. We really have a terrible state of affairs for how to take care of people once they are, if they are too old to take care of themselves, or if they are disabled and unable to take care of themselves. And currently that system, it's a mess. Either people spend enormous amounts of their own money, or if they're like most people who don't have enormous amounts of money, they spend down everything they have and then become eligible for generally highly institutionalized for-profit care paid for by Medi-Cal, with a lot of problems, right?
Yeah, you just gave me an idea. I say maybe I have a document about that shows how the spin down works. And I think that'd be good to show maybe next week for office hours. It's a big document. I would show it now with 4 minutes, but it's kind of a lot to digest. So next week on office hours, I can share that document because I had to share it because I don't even understand the spin down. It is convoluted AF. But you made me remember that, Ron. I'm sorry to cut you off. Go ahead.
No, that's fine. That's fine. Let's put that on the docket. So we actually come up with some good things for future office hours. But Maureen, I see your hand up. We've about 3 minutes.
I just wanted to add an anecdote to what you were saying, Ron. I knew a family who they're both college educated parents, African American. The mom had a master's degree, and they made they couldn't have, this is before the Affordable Care Act, they couldn't afford insurance, and they made too much to get Medicaid. And they had a son with a lot of developmental disabilities. He got some SSI, some care, but not enough. They needed more services for him. So they actually abandoned their jobs, and they started a janitorial company to clean offices at night so that they would not make too much money so they could get the proper care for their son. I mean, it was just heartbreaking. Two of the loveliest people ever. And with their educations and their abilities, and it's before, as I said, the Affordable Care Act, they just couldn't get health care. And because I think the husband had diabetes. So, I mean, that kind of thing is so tragic. And then estate recovery. I was with a group of primarily Filipino women who would not go on Medicaid. They were going without care because through estate recovery, when they died, their homes would be taken over by the state. And that's the only wealth some families have. They put their life savings into their homes so they have something to leave for their children. And to steal that from them, to take that from them after their death because they needed health care, that's just another outrage. I mean, these things are so, if you tell these to other people, they don't believe it in other countries. They can't believe the cruelty of the system. It's cruel. It's really a vicious system. And we have to treat it that way, which is why we can't accept people saying, well, maybe not now, maybe someday. No, it's too horrible. And it's on us to know what is going on. It's not okay to be living in this world, on this planet with almost 8 billion other people and not be aware of what's happening all around us. We need to pay attention. We are people of privilege and we need to do something about it.
Yeah.
Ron,
Thank you,
can I just jump in? I know there's only a minute left, but those are perfect examples. That family leaving their professions, that harms all of us. That harms all of us. Those families losing their homes, that harms all of us. All of our, you know what I mean? Like society, like it is so much richer to have them as, I can't remember what you said they were, but professors or whatever they are. We are so much richer for that. And look at the homeless situation. What is it, like 40% of homeless have jobs, but they can't dig themselves out of whatever debt they're in. And guess what that debt is? It's medical debt. This not having CalCare is is harming all of us, whether you see it or not. We would be so much further, almost in every area if we had CalCare, Medicare for all, single payer. Okay, I'm done. Thank you.
Thank you, Erica and Maureen. This perpetuates the generational trauma that affects a lot of communities of color. Why can't we build wealth? Oh, well, my house had a lien on it because of Medi-Cal. And so, this is bigger than just providing people, handing out healthcare as our more conservative counterparts in this state may say. This is not a handout. This is providing equity in the healthcare system that is completely defunct. And so I just wanted to close with that this is a health equity bill that will help communities like mine heal a little bit from the generational trauma that has plagued us for centuries. And with that, it is 7:01. So I want to thank you guys for joining us for office hours, and I'll let Ron, you close it out.
No, that's great. We'll see you all next week.
Bye, everyone.
Bye-bye. Thank you.